Yes, approaches to bereavement reaction.
Yeah, so I think I'm not going to go into this into too much detail, but what I wanted to perhaps say is that, you know, when someone has, divulged that they've lost someone, whatever, I know that you're timed, but it's okay to perhaps just kind of slow it down just a tad and just to kind of really show that, I'm sorry, as opposed to that, I'm sorry for your loss as a almost comma punctuation before you then go on with your doctor agenda. It's about just slowing it for that moment. So I'm really, really sorry for your loss. Are you okay to carry on with the rest of, of course they're going to carry on, but it just means that you've kind of really acknowledged that and the impact it might have had on them. And yeah, I just wanted to kind of put some of the approaches that you can consider in those who are bereft as a subtype of an adjustment to reaction. And as mentioned, there can be these time periods put on things whereby it's measured as kind of 6 months for an adjustment reaction, and then after that is a complex bereavement reaction. But whilst that is somewhat important, aspects of the risk, aspects of other symptoms that someone might be experiencing in other mental health realms, be it mood, anxiety, hallucinations, all of these things may help to infer whether the risk is higher and therefore whether you may feel that it might be a complex bereavement reaction earlier than that kind of classic 6 months. There's been mention after in the feedback about kind of signposting to various places. Don't forget about chaplaincy, if religion is kind of important to that person. Watch and wait approaches can also be considered in the context of normalizing how someone may be feeling. If you feel that there is actually quite low risk, then you might want to kind of book in for a follow-up appointment and give some normalization to what that person is going through in a context of their loss, and how that loss can sometimes bring up previous loss as well. So it can be kind of almost kind of re-traumatizing for people. So watching, seeing if that has occurred over time. And I mentioned some other things in terms of kind of pharmacological treatment and when you might kind of consider that in the context of bereavement reaction. It's not that we're trying to medicalize bereavement, but if you're feeling like things are getting to a particular severity, if the bereavement reaction is complex in the length of time, or the mix of symptoms that one gets, or the increased risk that one gets with it, then these might be times where you might consider expediting sort of pharmacological treatment. And then the resource in your area. CRUISE is an excellent kind of national organisation, and there are other types of organisations for different types of loss. But yeah, if you're concerned that someone may be a bit apprehensive to want to talk about things or be able to talk about things, that might be a situation in which you may expedite pharmacological treatment. And I've mentioned here below just kind of things you might want to think about in terms of how you might kind of manage the situation overall, proactive follow-ups, where you check their use of some of the interventions you signposted them to or referred them to, and considering of escalation if needs be as well. So in the age of this client, you might be thinking about whether they need to be escalated either to an older adults team, and you may even be thinking, if it's not suitable for older adults, do the older adult team members know of specific resources that they may use or signpost their clients to when they're de-escalating patients from their care, that you could use for this client instead of referring to them, or if they feel that the referral doesn't meet their threshold. So yeah, these are things which you can consider.